TopMedTalk.
Welcome to TopMedTalk. On today's TopMedTalk, Desiree Chappell, our co-editor-in-chief here on TopMedTalk and Vice President of Clinical Quality, NorthStar Anesthesia, has a conversation with Adam Spiegel, CEO of NorthStar Anesthesia, and Randy Moore, Chief Anesthetist Officer of NorthStar Anesthesia. Coming up, we're going to be discussing anesthesia staffing and leadership, pricing, reimbursement and payment cuts, and also industry trends and challenges in anesthesia. We begin with a point from Randy about how traditional hospital economics and straightforward expansion might now not always be the way forward. Have a listen.
Yeah, the interesting thing is, I know there's no such thing as a hospital CEO school, but if there was, day one, they would say, hey, if you build it, they will come is the best way to improve the finances of the organization or of the hospital, meaning open up capacity, open up rooms, give surgeons flip rooms, compete with other facilities for surgeon availability. That's the way out of this. And the interesting thing is, that's actually not working when it's on the hospital economics. And Adam, I'm curious, is we have some tough conversations with our hospital partners and prospective hospital partners. Yeah. And there is this knee-jerk instinct to keep capacity wide open. Talking about decreasing capacity is actually kind of, for many of them, a counterintuitive direction to go. How are those conversations? Do those conversations look different today than they did 2 years ago? Mm-hmm. And if so, why is that?
Yeah, so there are a couple things, and I think this is helpful for anybody who's working with administration. Starting from a point of data is really important, because if you go by anecdote, I can't tell you how many CEOs of multi-billion-dollar systems tell me, well, I know you're telling me that we have too many ORs, but I talked to a surgeon yesterday, and he told me he couldn't get his elective case on. Yeah. So clearly, we're not running effectively. And I'm like, okay, you're using, an anecdote from one surgeon. I'm not sure this is exactly how you want to run your multi-billion-dollar health system, but, don't let me tell you what to do. So I think it's really important to ground everybody in data, which is what actually is utilization. When do we see cases late? How is that playing out? And we are spending a lot of time focusing not just on anesthesia cost, but on OR cost, because while the anesthesia provider issues are well known, it's just as hard to find PACU nurses, just as hard to find OR techs as it is CRNAs. And hospitals are spending a lot of money on agency in those areas as well. And I think if we can kind of show them, hey, this is the cost of every extra OR hour, it makes a difference. So I think that's one thing. I think the second thing is there is natural hospital executive turnover.
Yes.
And the reality is the guy or gal, but usually they're guys, who got hired to grow the place gets fired. The new person comes in and their job is to cost reduce.
Yeah.
And I think when you get that cost reduction person in place, that's the person that you end up having a much more successful conversation with in terms of reducing things. So sometimes you try to be data-based, you try to make the persuasive arguments, but it sometimes does require some turnover for us to get our message across.
Yeah. And sometimes I think the turnover may be a little bit scary because you never know what you're quite getting there, but it sounds like there's some rational conversations that are happening now as we move forward.
Yeah. And I think it is a little bit facility by facility, but I think what you're finding is that when hospital financials are down, the initial thing is we got to grow. And then they look at their financials 12 months later and they say, we got to cut.
Yeah.
And it's in that cut phase that you can actually make a pretty cogent argument of, hey, you don't have to fire people. You just reduce your OR time and get rid of your agency stuff. And, your economics are going to look a lot better.
Yeah. Those conversations are sometimes hard. I think one thing, and this is kind of to take it to the front lines a little bit and how we're supporting them. I feel like one of the things we do really well is communicate that to our teams so that they know that, creating culture, doing all things, but also having leadership skills to be able to go in and be kind of our front line supporters and advocates for all of those things. Would you?
Yeah. And I think one of the things that's really important as well, and I think this is, again, we try to do this, but for anybody who is looking for a leadership position within anesthesia, is it's really important to be a great team leader. Yeah. Obviously, you want to create a great culture, but it's also important to really understand the business levers. And we really try to push, because I can talk till I'm blue in the face to a hospital CEO about what's going on. The real action is the conversation between the chief and the OR director.
Yeah.
Because those are the people and the medical director. And that sort of triad group working together, they're the ones who really decide, hey, how much OR space do we really need? Can we do some things about capacity? Can we actually have a rational conversation with some of these surgeons? Those are where the real action happens. So I can have all these conversations at a CEO level, but it's when the chiefs are having good relationships with the OR directors, that's when you actually start to right size some of these ORs. And I think that's why it's really important for our leadership to really understand not just how to be a good clinical manager,
Yes.
but actually the economics side of it as well.
Yeah. Randy, I think that's unique for us. And I think you've really been leaning into that and really trying to develop our leaders to be able to empower them with that knowledge and those skills.
Yeah, I mean, the interesting thing about the days of anesthesia staffing companies being an easy business are long gone.
Yeah.
And so what we're seeing happen is companies that are responding to that and are pivoting towards, okay, I guess we've got to run our company like a company
Yeah.
operationally instead of basically a scheme to win rates and then to drive profitability through that. Well, guess what? Surprise billing, which Adam's going to unpack, I'm sure, has evaporated a lot of companies' competitive position almost overnight. And to be successful, you actually have to have operational excellence, and you actually have to have frontline clinical and operations leaders for sure who are driving performance at the site level. And you can see there's a culling of the herd that is happening. And some of it is just because the economics have just got really, really hard. Other part of it is like, there's been so much easy money in this space for so long. And now that things are hard and really hard, the basic blocking and tackling of being a company and running sites efficiently, effectively, and leveraging clinical leaders and getting as much as we can in terms of their impact, like that is critically important in a way that wasn't the case 3 to 5 years ago. And so I think that's part of like these companies who have a lot of size and have grown because they've bought other companies are really in a very tough position.
Yeah.
Because culture is an afterthought and leadership performance is often what they play. They play there's some lip service to it, but are they making investments? Are they thinking short term or long term? I think those things are actually really important right now.
Yeah, absolutely. Well, let's pivot just a little bit and talk about some of the reimbursement pieces. We did start that conversation last year. I think the No Surprise Billing Act was just really starting to kick up and starting to realize some of that. Adam, I don't know if everybody understands all of that, especially for people that may not be here in the US. Can you unpack that just a little bit and start with that? Maybe we can go in some other directions here in a bit.
Sure. So basically, if you look at, and some of this stuff has been in the news about, these evil private equity groups that are raising prices for poor United Healthcare, who's clearly really struggling with their bottom line. Yes, exactly. But for most places, especially in urban markets, if you are an orthopedic surgeon and you're by yourself, you're going to get a really bad rate because the payer says, hey, you either are in network with me or you got to go figure out how to get a bunch of out of network patients. So what a lot of orthopedic surgeons do is they get together in big groups and those groups get bigger and bigger and bigger so that they can have an equal conversation with the payer. And they say, look, our costs have gone up 20% this year. We need you to pay us 20% more. And United says, no, I'm not going to do that. And they say, okay, well, I'll go out of network and I'll charge you 40% more. And United says, well, maybe we can work something out. And then, you end up back and forth, but you get a negotiation where you're going to get reimbursed to help cover the increased costs. And this happens in orthopedics. It happens in cardiac surgery. It happens in, even large, you see a lot of these large primary care groups doing the same kind of thing. For years, that was the play with anesthesia. And whether it was a private equity group buying up a bunch of these practices or just independent practices getting together, they did the same thing, which was we need enough market share so that if we go to a payer and we say, hey, look, we've got higher costs, the payer had to take us seriously because that risk of going out of network is something. Well, the unintended consequences of the No Surprises Act and the real impetus behind the No Surprises Act was once you agreed on a payment for the payer that was out of network, a lot of anesthesia companies, radiology companies, air ambulance companies would go after the patient for the remainder of the month.
Yes.
And one is that's not a great practice and people shouldn't do that. Now, most reputable companies weren't doing that anyway, but some were, and that's a good reason for the bill. I think the other thing is at the end of the day, patients don't get to actually choose if their anesthesia provider is in network or out of network.
Yeah.
So the idea behind the No Surprises Act is, look, if you don't have to choose your provider, well, then you as a patient don't have a chance to look at in-network versus out-of-network. So those were noble ideas behind it. What happened, in fact, though, is now because United can pay me the whatever in-network rate they want to make up, basically what happens is I go to them, same thing. So that orthopedic practice says, hey, 20% now, 40% out of network. I have the same conversation with United. I say, look, our labor costs have gone up 30%. We need a raise. And United says no. And then I say, pretty please, because I can't actually kick you out of network because they're going to pay me whatever they want out of network. And in fact, United says, it's funny you bring this up because I know we've got an in-network contract. I'm going to have to reduce that by 20% because I think you're on the high end of what I want to pay for anesthesia. And if you don't take that 20% price cut, I'm going to kick you out of network and I'm going to pay you 40% less. So you decide what to do. So we've been in this environment where reimbursement is actually going down while labor costs are going up. And it creates a really tough problem because the practice management firm can't pay that. And obviously the providers have to pay it. So what ends up happening is the costs all get passed on to the hospitals.
Yes.
If you are not on top of your financials really well, you get caught in a spiral. And I think you've seen a lot of businesses sort of go out of business, give up, sort of say, hey, I don't want to be in the practice management business anymore from an independent practice perspective. And you've seen a lot of large players have similar problems because they've kind of gotten caught not realizing the impact that the No Surprises Act has had.
Yeah. Over the last year, we've seen a little bit of movement in this space. I mean, do we have an advantage or, some way that we're trying to combat this as a NorthStar organization, but team anesthesia?
Yeah, I think the most interesting work that's been done in terms of fighting back on this one is I think a lot of the large practices, ourselves included, have really pushed through the independent dispute resolution process, which is you basically can say, hey, what United's paying us for anesthesia is too little. So I want them to pay me more if we're out of network. And therefore, I'm going to go to an independent arbiter and that person's going to decide who wins. Is United right or is NorthStar Anesthesia right? And this is happening around the country. Small practices, large practices are going through this with the idea that over time, if we win, theoretically, rates should go up. And I think nationally, the win rate is in the 70 or 80% range. So in general, physician practices are winning a lot more than the payers are in these situations. I think the problem is it costs a lot of money to go through this process. And at the end of last year, CMS raised the cost of doing it significantly. So what we've done to try to combat this is in Texas in particular, the AMA, the ASA, similar organizations for radiology and for ED medicine have gotten together and sued the federal government around some of the provisions of the No Surprises Act. And we've won multiple cases. I think that has helped a lot in terms of trying to make that independent dispute resolution process more fair. So I think that's great. And we're making some progress there. The flip side is, the payers are a multi-headed hydra. You sort of cut off one head. And then the other side of things is, I think your listeners may know that Cigna has cut rates for non-medically directed models by 15%. So if you're using CRNAs, you're getting paid 85% of what you get paid if you were using physicians. And again, I don't know what their justification for doing that is, but
I've got an idea.
But
probably
what's happening right now is if Cigna's going to do that, they're going to be followed shortly thereafter by the other payers. And basically, it's a way to save 15% of your anesthesia spend.
Yeah.
And this is another thing that our organizations are out to combat. The real challenge on that one is that it starts to create a world where it actually doesn't pay to use CRNAs.
Yeah.
And it's actually better to use physicians in a lot of these models. So I think this one is, while I would argue the ASA has been kind of carrying the water on the No Surprises Act, I think the AANA is going to have to get more and more involved on the Cigna type cuts because I think it's going to have much more of a direct impact on CRNA staffing in the future than certainly the No Surprises Act, which impacts all of anesthesia.
Yeah. Right now, I know you can ask questions if you want, but I do have a question for you. How do we relate to this as a frontline provider, CRNA in the room every day? Like, how does this impact us? And, what are we talking about in NorthStar to get that message down to our frontline providers?
I mean, part of it is that, all of this, I think I would probably zoom out a second and say, like, how does some of these macro trends that Adam's talking about, 30% increase in CRNA and physician compensation in a 2 to 3 year period. Some of the decrease in reimbursement that's happening at the same time. And oh, by the way, what's driving the 30% increase as there's supply demand imbalance of CRNAs and docs, by the way.
Yeah.
All of that is creating some challenges for our frontline clinicians because they're looking to their left and they're looking to the right, and they're seeing that there is a 1099 CRNA to the left and a locum tenens CRNA to the right. And that's not a good feel when you see that they're making, because they are mercenary workers, making a mercenary wage.
Mm-hmm.
And I think the way that we are thinking about this stuff is that, and we alluded this to a little bit earlier, is that, we really want to, CRNAs and anesthesiologists absolutely should be paid a fair and competitive wage.
Mm-hmm.
And we advocate quite often for that with our hospital partners. And sometimes those conversations take longer than they should because the decision-making process with the hospital and health system partners is complex because they're also dealing, honestly, in an honest moment, they're dealing with a lot of stuff coming their way. So for us as a company, we are, trying to communicate consistently to our teams that, yes, you deserve a fair compensation, and we're advocating and we're moving the needle. Adam can give you some data in terms of, we've renegotiated over the last couple of years tens of millions of dollars that have all gone back to our clinicians, right?
Mm-hmm.
And so there's that. The other part of that stuff is, if you think about the way out of this, is obviously we got to increase supply. We've got to have a rationalization of demand. And then I go back into, I know I sound like a hammer chasing nails, but it goes to culture, right?
Yeah.
So I think we got to create a really attractive culture, because what we see is, in some sites, when let's say we come in, we've been awarded a contract, the culture's not where it needs to be. That's part of the reason why we were awarded the contract, and we need to get in there, is that it's a very transactional workforce there, because there's no culture, there's no teamwork, there's no team orientation. And our first big priority is making sure we have the right leaders there, and then those leaders build culture. So I think, that's how I would think about that as a frontline anesthesiologist or CRNA, is making sure that I'm in a place where the compensation's fair and competitive, but also the culture is there as well.
Yeah. True. Well, guys, we need to wrap up here today. As we go out and leave our conversation, Adam, what are some of the things we talked about? Challenges, because these are all challenges that we're facing. What are things that you're really excited about for this next year for NorthStar and for anesthesia in general?
Yeah, I mean, I think that this, again, it's hard because the financials are tough right now. But getting back to where Randy was going, I think what this means is when there's a lot less time focused on, hey, how do I maximize my rate?
Mm-hmm.
And more time focused on, how do I actually become a better anesthesia company? It's good for everybody.
Yeah.
And I think what I'm excited about is, in some ways, it allows us to focus on what matters, which is, hey, how do we provide better care to our patients? And, we always see the perspective of the best way to do that is to provide a great working environment for our clinicians. And we're not going to be the only ones thinking that way. And I think that's probably the best news for all of our clinicians, which is, look, the way you win here is you have to be able to staff your sites. The way you're going to be able to staff your sites is creating a great culture. That's not an insight that NorthStar alone has. That's going to be out there for the industry. So hopefully, as you start to look over the next couple of years, what I'm excited about is, these large practice management companies, these small independent practices are all going to be focusing on the same thing, which is, how do we create a good environment for our teams?
Yeah.
And that's great for everybody.
Yeah, absolutely. Gentlemen, thank you so much for sitting down. It's a great conversation. Always good to hear from different perspectives, especially from a CEO from a large company, of a view that most of us do not. So thank you for sharing that and sitting with us on TopMedTalk. Randy, cheers to you. Thank you very much. And thank you for listening to TopMedTalk. You can always find us on your favorite podcatcher, social media, Twitter, LinkedIn, Facebook. We are there. TopMedTalk, we have over 2,000 conversations that we've had over the years. A lot around the business of anesthesia, which I think is really interesting topic that we can always learn more about. So do check that out. Cheers, everybody. Have a great day.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out edpom.org now.